And we are live. Welcome everybody to the first chapter leader Q&A live stream. I'm Mike Wayman. This is Bob Wayman, my dad, from NCAN. And today we've got Dr. Robert Ramirez from Vanderbilt in Nashville, Tennessee. How are you?
I'm good. How are you doing, Mike?
Great. So this is kind of the first time we're doing this format. So, hopefully you guys like it. I think it'll be pretty cool. For those of you who just have the link and want to ask questions, don't worry. You don't have to sign up for a YouTube account. You can certainly do so. You can leave some questions in the comments where we will get to them, but you can also text questions in. We have the number rolling across the bottom of the screen here, and also just if you don't see it, it's 516-584-4576, and we'll try and get to all your questions. We have a nice block of time set up for Dr. Ramirez, and he's got a pretty short presentation before, and it'll give you guys a little bit of time to send us some questions. So again, that number is 516-584-4576. I'm excited.
Yeah, this is great. I just want to mention it's not just the chapter leaders today. So those of you who aren't leading a group, you're in the right place.
Yes, we want to make sure that we give everybody involved with chapters a chance to to interact with doctors, and it's really important that you get involved with the chapters. Hopefully, moving forward, I threw some ideas to the chapter leaders about maybe doing some live stream viewing parties and stuff like that, making your meetings kind of an interactive thing. So Dr. Ramirez, without further ado, I guess we'll give the floor to you, and we'll pop back in when you're done with your presentation here.
All right, great. Thanks so much, Mike and Bob, for having me today. This is it's really cool to be able to work with your organization. I guess I've been working with you guys for a number of years now, and as well as with the local chapters, and I really see the benefit. I see patients come and talk about their local organization. Certainly, you've got the national meeting coming up in November, which I hope will get lots of patients and caregivers to come out, because I think it's really important. It's going to be a great meeting with. There's over 20 docs speaking, and so this is the time to get up close and personal and just ask those questions, and even when I go to these meetings, I always learn a lot from just listening to the other speakers. So hopefully we'll get a chance to meet some folks out there, and certainly. I put my email on here. I'm always available to answer questions, and a lot of times if you're asking specific questions, I obviously can't get too specific many times, but maybe at least I can offer some knowledge and get you pointed in the right direction to best navigate this disease. So for those of you who don't know me, I'm Robert Ramirez. I'm a medical oncologist at Vanderbilt. I specialize in the treatment of neuroendocrine tumors and thoracic malignancies. I've been at Vanderbilt for almost a year and a half now, and prior to that, I was in the New Orleans program. So I've been taking care of neuroendocrine patients for quite some time now. What I want to, if you found your way here today, you're probably very familiar with neuroendocrine tumors. So I'm not gonna. I want to kind of put a superficial view over everything, and I won't get into a lot of the specifics on treatment. We can certainly talk about that, but this is more so to I want to hear from you and answer questions, and really talk about some cases and how we would manage things. So with that, let's talk about neuroendocrine tumors. So as you are probably well aware, these are rare cancers. They can occur anywhere throughout the body. We see the majority of these start out somewhere in the abdomen, in the small intestine, large intestine, pancreas. As a thoracic oncologist, I see many start out in the lungs. And there's not, people, we think about risk factors for many other cancers, including lung cancer. We think about smoking as a major risk factor. And other cancers have risk factors. With the neuroendocrine tumors, there's not too many risk factors. We think, every now and again we see a genetic syndrome that can put you at a higher risk of this, but most of the time, these types of malignancies occur sporadically. It's interesting that because they have pretty uncommon presentation. So symptoms really, really vary, and it sort of depends on a couple different things. If where the tumor is located. So for instance, if I have a patient with a tumor in the small intestine, sometimes patients can present with a bowel obstruction, which people come in with abdominal pain, nausea, or vomiting. If it happens in the lungs, sometimes people present with cough or wheeze, shortness of breath. Sometimes people cough up blood. Many times there are no symptoms, and these get picked up incidentally. So it really depends on the location. And then there's, as many of you know, there's what we call functional tumors where there can be hormone secretion. And so sometimes patients will have diarrhea for many, many years and get seen by the GI doctors and get treated for IBS or something different. And then it's not until somebody does the right workup that a tumor is found. They're misunderstood in many cases. It's a rare cancer, so it's hard to know everything about the presentation, and that's why there's often such a delay in treatment. I have patients that have symptoms for many years. And like I said, get labeled as something else. I've had patients this week that have a new diagnosis of a lung tumor, and on their scans, if you look back 5 years, that tumor was there before, and just overlooked or felt to be a benign nodule. And so I think unless you're really kind of thinking about this, you'll tend to miss it. There is what I think is a lack of research into this arena, but I think we're getting better at this, and I think more and more people are getting interested in this. But it still relatively represents a minority of research. I mean, compared to obviously some of the more common cancers. But despite that, there are many, but not too many treatment options. So we have a limited arsenal. This is not breast cancer where we have 20 different options for treatment. But again, I think we're getting better, and I think we're certainly better than we were 5 years or 10 years ago. So I think many of you have seen this slide. This talks about the incidence of neuroendocrine tumors increasing, and we think it's probably better, linked to more awareness, better pathology techniques, more imaging. Let's face it, every time, if you go into the ER with a sprained ankle, you're probably going to get a CT of the chest, abdomen, and pelvis. Rightfully or wrongfully so, and sometimes these things get picked up that way. So speaking of imaging, so what's how do we work this up? So if you we're familiar with the CTs of the chest and the abdomen. So this is a CT of the chest. This is a cross-sectional image. Here is the left lung and the right lung, and we see a big mass right there. So we don't know what it is yet, but ultimately this we'll get an answer on what this is. We use MRIs for the abdomen, especially if there's liver metastases, and then the functional imaging. So there's two PET CTs, dotatate PET CTs in the U.S. that we use. There's the gallium-68 and copper-64 imaging, and this really is this represents the standard of care for workup of neuroendocrine tumors.
Hey, Dr. Ramirez, just so you know, your slides are not advancing.
Oh, wow. Okay. Can we fix that? Anyway.
You're going to have to go into your, there you go.
Okay. Are you able to, you're able to see this now?
Yep. Now it's changing.
Okay. All right. So this was that famous slide that I just discussed. All right. So imaging, again, this is a cross-sectional image through the chest. Here's the left lung, right lung. Here's the big lung mass. Here's the PET CT indicating some uptake in this area. So again, I was talking about the role for dotatate PET CT. Again, represents the standard of care for workup of patients with neuroendocrine tumors. Every now and again, I see an Octreotide scan ordered. We will sometimes use this or use whatever comes through to us, but we'll automatically get somebody set up for a PET. The Octreotide scan is an inferior test to the PET. So if your team asks you to go get an Octreotide scan, ask them to rather than that, see if we can get a PET. All right, so you have a mass. What do we do now? Well, we don't know what it is. That mass I showed on the prior slide could be non-small cell lung cancer, could be small cell lung cancer, could be something different. We really need to look at it underneath the microscope. So we need a biopsy. And depending on where your tumor is located, we look at different types of biopsies. So if it's in the lung, we can use a bronchoscopy or endobronchial ultrasound that takes a tube down into the airway, and we can do biopsies that way. We can do something called a mediastinoscopy, where they will take a scope down into this area in the middle of the chest. Sometimes we do this under CT guidance with the radiologist. Same with the liver, or someone has bone lesions, we use the CT guidance. If it's in the bowel, we will tend to use endoscopic ultrasound, or sometimes we get this with a colonoscopy. So there's different ways to do this. And so when we look at, so we have a biopsy, it gets sent over to the pathologist, and what are we really looking for? And when you look at your pathology report, there are certain things that should be included, and if they're not, we need to really send it back. And we at Vanderbilt, we always will have our pathologists look at this whenever we get somebody from the outside, because things vary. So many times I'll get a pathology report from an outside institution, and it says neuroendocrine tumor. Now, so that tells me one thing. So we're dealing with a neuroendocrine tumor, but there's really quite a big variation in neuroendocrine tumors. So what we want to see on the pathology report is the differentiation status. So is this well differentiated or poorly differentiated? And basically that tells us how similar or different does this look compared to usual tissue. If it looks very different, it's called poorly differentiated. We look at the Ki-67 and mitotic index, and essentially this is how many cells are dividing. So the higher the number, the faster the growing cancer. So, and we break them into grades. Okay, so in the well-differentiated setting, we have 3 grades. And again, you can see the ranges of the Ki-67 between grades 1, 2, and 3 and the mitotic index. So these are, again, these are things that you want to see on your pathology report. And sometimes it's buried in the text. We will also see the poorly differentiated grade 3. We call this NEC, or neuroendocrine carcinoma. The Ki-67s are over 20% similar mitotic index, and many times the Ki-67s range over 50% or higher. So this is usually a very fast growing malignancy. So one of the biggest things is to find your multidisciplinary team. So it's important that patients be discussed in a multidisciplinary setting with all of these folks that you see before. We have a neuroendocrine tumor board that we meet with the oncologists, radiologists, nuclear medicine, surgery, interventional radiologies. There's a whole team that sits around, and the tumor boards are interesting, and it's the way it's set up. It's set up on Zoom now. We used to do this in person, but we all meet. We all log in and can see each other, and we start with the cases. So for instance, the way it would work is, I would say I have Mrs. Jones. She is a 53-year-old woman with a history of a pancreatic neuroendocrine tumor who underwent surgery. Had a Whipple procedure 2 years ago, and she comes back for a follow-up, and here are the new scans. And then the radiologist will say, all right, we've reviewed these scans, and then actually put up the scan. And for instance, again, this is all hypothetical. So Mrs. Jones has developed these liver lesions here, here, and here. And then we say, all right, we performed a biopsy, and then the pathologist would come and put up slides and say, all right, this is the biopsy, and it is showing a neuroendocrine tumor, grade 2, Ki-67, 10%. And then we go back to radiology and say, all right, this is our go-to-tape PET, and we say, oh, there's a bone lesion on this side, and then it flips over to, all right, what are the options? Are we looking at liver-directed therapy? And then our interventional radiologist may chime in. Or our surgeon. So that it's a whole team, and then at the end we say, all right, well, these are the recommendations from tumor board, and then then we either call the patient or have them come into the clinic to discuss. So and then we move on to the next patient. And sometimes tumor boards can be, it's really good because everybody has an input, and we go back and forth, and we talk about, all right, what's the evidence for this, and why should we be doing this? And so it's a very good tool to use, and patients should ask about, are they being discussed in a multidisciplinary setting? So for instance, so we have this patient here. We have a large lung mass here that you can see on PET, but you also see this. This is a spine that lights up right there. So that's a bone metastasis. Here's someone different with a tumor right there that you see on PET. These were both atypical carcinoid tumors of the lung, but they're treated very differently, even though they're the same, diagnosis. So it's important. Again, it's a multidisciplinary setting. That's very important. And the biggest thing is choosing the right treatment at the right time. And so that's where you get your team involved, and really, you are also part of this team. So make sure to ask your questions, and make sure you are comfortable with where your treatment is going. I often tell patients, you've got one shot to get it right. So we want to do things right the first time. So what are the options for treatment? Some of it, is really dependent. So what are the goals? Is this someone with a small tumor that with no evidence of metastatic disease, that we can take out, throw in the trash can, and hopefully get rid of this disease entirely? Or is this someone who is already presented with metastatic disease, and the goals there are to improve quality of life, and hopefully that translates into longer survival? So we look at surgical treatments versus non-surgical. So are we able to do an operation, or is this medical management? So with this somatostatin analogs, or targeted therapy, or PRRT, these are all things that we look for, and again discuss in our multidisciplinary setting. So what are the benefits of treatment? Again, is this for symptom control, or is this to try to get rid of this? And then what's next? As an oncologist, when a patient comes to me, I'm always thinking, I generally know what I'm going to do up front. But I'm always thinking, all right, what happens when my patient comes back and they've got growing disease? And I always try to get one step ahead, and say, all right, well, this is going to be the next thing that we're going to do this for this much time, see how much mileage we can get out of it, and then we're going to move on to this, and then after that we're going to move on to this. So that's always something that we're thinking about, and newer things are coming out, and so what's next may actually change. So questions for your team. So again, what is my diagnosis? Do I have a neuroendocrine tumor? Or do I have a neuroendocrine carcinoma? What stage am I? We didn't talk about that, but certainly it's important to know that, because treatments are based on stage. Where's the disease located? Is it in the small intestine? Is it in the small intestine, liver, lung and bone? You sort of want to know. And when I have patients in the office, I always go through the scans and say, all right, well, this is what we're dealing with. And your disease is started here, but is spread to here and here and here. And so we kind of get an idea, just what we're up against. Again, we talked about what's the pathology, what does it show? What's the grade? What is that Ki-67? It's, these are all things because your treatment options are going to be based on that. So what are the options, and how did you come to that recommendation for treatment? What are the alternatives to that recommendation? Do I need to do anything? Some patients we don't necessarily. Some patients we can observe. It's every now and again we can do that. Importantly, do you work with a net specialty team, or have you worked with it with this? So we see patients from all over the country, and we sort of act as the quarterback for that team. And we send our patients back to, most of our patients can be managed closer to home. And so, but it's good to have that expert opinion, whether it's with us or another net specialty center. So, in most of the time, oncologists are very happy to see that that patients are seen in that expert center. ask about clinical trial options. Again, there's more and more clinical trials that are coming out, and that's how we move the field forward and get better options for treatment is through clinical trials. So are there options? And then can I get a second opinion? I think second opinions are very valuable. Third opinions are valuable. So you got to feel comfortable with where you're, what you're doing and where you're at. So yeah, if someone says nope, you can't get a second opinion, I think that's probably your first clue. You should get a second opinion. So that's just what I have. Just a short overview of everything today. Really, I wanted to kind of open this up and ask, talk about, answer questions and, see how I can help, with your disease and help, give you some guidance here.
Thank you for putting that out there. I really appreciate the presentation. We do have a few questions. We've gotten a bunch of questions here. First off, we have from the YouTube page. I have not seen a surgeon for a follow-up since Whipple surgery in December 2016 at Vanderbilt Hospital. What timeline do you recommend I have a review? No known tumors per Octreotide scans currently.
Yeah, so normally patients, once they have a resection, we don't say, all right, we took your tumor out, goodbye, you don't need to see us anymore. Okay, we get those patients all the time because sometimes they'll recur. So yeah, it's important to have surveillance. Normally, what we'll do is we'll surveil with conventional imaging with CTs. Every now and again, we'll surveil with the PET CTs. It sort of depends on the presentation. So usually we will do CTs at 6-month intervals for about 10 years. So to surveil with an Octrea scan is a little bit unusual. Again, we don't do Octrea scans anymore. I haven't ordered one in a number of years actually. So it may even, it may be worth a conversation as to, what is the best way to undergo surveillance.
Perfect. We also have, is Vanderbilt Ingram going to be doing an alpha PRRT clinical trial in the near future? If you have previously had beta lutetium 111, PRRT, would that knock you out of the trial?
Yeah, so the answer is yes. We actually have a trial that is going through the regulatory process and hopefully will be opening shortly. This is a trial using Actinium, which is an alpha emitter in patients with GI or pancreas neuroendocrine tumors who have seen lutetium in the past. So yes, stay tuned. We're excited about this. The alpha emitters are really exciting, and we were very excited about lutetium when it came out. And this is just that next, the natural step in trying to make things better.
Yeah, Dr. Ramirez, I want to just jump in here for a second. You answered this question, I think, quite well, but it's kind of an important one, and I'd love you to just kind of glance over it again, because it's something that every time I hear someone speaking about, okay, we're going to go to our tumor board with that. Being a New Yorker, I'm a little suspicious of that. But they're asking, when a Vandy patient hears our tumor board will review your case, what does that exactly mean? Is it like you and a guy from YouTube somewhere talking about it?
No, these are all Vanderbilt physicians, and again, it's a whole team, and so before COVID, it was great. We would come together at noon on or in the morning, and we'd sit around a big table and have our lunch and order coffee, and we'd go back and forth. We'd have a big screen, and we would say, all right, here's the scans on the patient, and talk about the patient. And again, we can do the same thing on Zoom. It's just a little less interactive, I guess. But yeah, I mean, that's exactly what it entails, is people who see this on a regular basis and coming up with individualized treatment options for the patient.
Perfect. Well, thank you.
Maybe we can at some point we can talk about doing a mock tumor board at one of your meetings.
Yeah.
So you get a really good idea how that goes.
That'd
be awesome.
Fantastic. Yeah, we have another patient who's asking, can they just go to you and make an appointment? Do they need to, be referred by a local oncologist, or how do they get an appointment with you?
So yeah, you can. I guess it depends on your insurance whether or not you need a referral, but certainly, you can certainly call us or send me an email, and I send it off to our navigator, and we can get you set up. When it comes, I do a lot of telemedicine. The issue with telemedicine is we need to have the patient in the same state as where we're licensed. So in the past, when we first started doing telemedicine after COVID increased, the licenses for physicians were very easy to obtain. They said, all right, you can work across state lines, but all of those have gone away. So now we're left with, well, you can still do telemedicine, but patients need to be in that particular state. I've got patients I'm not licensed in Arkansas. I've got patients in Arkansas who drive across the border and they're in Tennessee, and they get me on their phone. So it's a little challenging, but sometimes it can save patients some travel time.
Great.
Cool.
Great.
Just a reminder to everybody watching, again, you can text your questions to 516-584-4576, the number that's scrolling down at the bottom of the screen. We have another one that came in. If your local oncologist doesn't think you need a multidisciplinary team, what is the best way to set one up for yourself?
Well, you can, again, it depends on where you're located. You find your own specialty center. I think patients, especially this group of patients, they're very good at advocating for themselves, and I really am impressed with this, and even just doing this type of meeting you guys are doing, it's really good. So yeah, I mean, none of us are going to turn you away and say, no, you don't need a specialty center. And and many times we agree with your treatment plan already and say, yep, Dr. Jones is doing a great job, and I don't have much to add. Or there's also many times that we say, why don't we try this, and and you can do this back at home. And like I said, when we're talking about this, 1% of cancers, the people who are seeing the primarily breast and lung and colon and prostate and all the common cancers, usually they're pretty happy to have that expert opinion come back.
Yeah, I think that's an excellent point. If a local physician doesn't really want you to go somewhere, maybe that's not the right doctor. I don't know, because I've never really spoken, and as you guys know, Marianne is a patient for 20 years. And anytime she saw a local physician and said, hey, we have a specialist, they would say, by all means. So I'm not sure why they would say no, but you'd have to just make sure you inspect that patient and make sure that that's a good idea. We have just another one, Mike. I want to follow up. It's a nuts and bolts of the system type. After getting a self-referral, patient wants to know if they have, I guess, a diagnosis that they can send you notes or something of carcinoid syndrome with an unknown primary. Is that okay for you, or do you need a confirmed biopsy?
So carcinoid syndrome. So symptoms alone, it sounds like.
Right. Yeah.
So yeah, that's challenging, and we see this from time to time. If the symptoms warrant, there's a lot of different testing that we can do to confirm a diagnosis, but ultimately it comes down to having tissue. Wherever that may be. But we're very good at saying, all right, well, let's look at our markers, let's look at our imaging, let's look at our conventional imaging, our functional imaging, scopes, all of these things, and really, if there's a strong enough suspicion, chances are we can find it.
Got it. Anything else coming in on the screen, Mike?
Yep. You know what? Ask one more. Just trying to get this to load up here.
Okay, no problem. We have another patient asking, with improved scans and diagnostic tools, seeing an increase in gastric nets primaries. I guess that's the lead-in. Is there a specific gastric net specialist at Vandy, or are you and Dr. Das handling the different locations of nets?
Yeah, we see when we talk about gastric neuroendocrine tumors, so stomach. Many of these types of tumors are handled by the gastroenterologist because patients will need scopes periodically. But between myself and Dr. Das, we also see this, and the majority of them can be handled by gastroenterology with periodic scopes. But yeah, we certainly see this, and we're part of that team.
Okay, so I have here, I'm non-functional lung primary in the bronchial, 1.2 centimeters metastasis to the liver, 2 tumors, 1.2 centimeters each with 15 lesions, Ki-67 less than 1%, stage 4, grade 1. So far, watch and wait. There's no plan to remove the primary. But is that something that you would support?
So again, without seeing scans and seeing the patient, obviously I can't offer specifics on things. I will say a watch and wait approach is sometimes appropriate. Now, where I think this is appropriate is symptoms. So if a patient is completely asymptomatic from this, this is somebody and asymptomatic, and then 2, if I can look back and see scans from 5 years ago, and everything is exactly the same, I feel a little more comfortable with that watch and wait approach. Where I think about treatment options. Moving in a lung net anyway, where I think about this as all right, so are there symptoms, or 2, do I see disease growing or new disease happening? So that's when I start thinking about treatment. So in an asymptomatic, otherwise long stability of disease, I think a watch and wait approach is appropriate. When it comes to the other part of the question was, do you resect the primary tumor in a lung? In someone with metastatic disease, it probably doesn't make sense to go and do that unless there's something about that primary tumor that's causing problems. So sometimes we'll have an endobronchial tumor that is obstructing an airway, causing symptoms of shortness of breath or coughing up blood. That's somebody that maybe we would go down and do what we call an endobronchial therapy, where we actually take there's different ways to do it, but actually take that tumor out of that airway. That does not mean that you're not going to run into other issues down the line. Your disease is already spread. So the only time I would go in and resect a primary in a lung would be in those circumstances, or if it's a functional tumor. So, for instance, an ACTH secreting tumor that's causing Cushing's syndrome, well, then there may be a role to try to take out as much as you can.
We got another few actually. Same patient. Doctors only talk about survivability of 5 years once metastasized. Are those with longer survivability ones where the disease has not metastasized?
So survivability, I guess, I hate to put numbers on people. I can quote the statistics, and you say 90% survivability at 5 years in a typical carcinoid, and less than that in an atypical, and for the small cell, less than that. But everybody's different, and I'll be the first to admit I'm really bad at thinking all right, this is how long my patient is going to live, because I get fooled all the time. I'm good if it's I think we all can determine in someone who has days left, the survivability. But when you have that new patient, I will rarely talk about this is what I can expect. And, because again, I've been fooled. Even with the higher grade, my small cells, you look at the median overall survival with the best treatment. It's not that great if you look at the literature. At the same time, I've had patients who do really, really well, and outlive their expected survival. So I try not to put numbers on people.
Sure. Is there any estimate on when Actisium 225 trials might start?
Hopefully by the end of the year at Vanderbilt.
Awesome.
So I think they're probably open at other institutions. There's another alpha emitter called Lead-212, which is also at several different centers as well. So I think the alpha therapies are making their way through.
Great.
Just as a quick follow-up to that, what are upcoming treatments or diagnostic tools are you most excited about?
The thing I'm most excited about is the alpha therapy. I mean, I think the early results are really, really impressive. So that's what I'm most excited about. There's also we're looking at different molecules or different immunotherapies and trying to put combinations together. So that's exciting as well. So there's a lot of different things that are coming out, and that's why we always advocate for clinical trials, because that's how we learn how best to treat patients and how we advance the field.
Yeah.
We've got another question in here. What is the best protocol for carcinoid crisis in the emergency room?
So, carcinoid crisis is felt to. So this can happen when you have an over secretion of hormones, leading to a drop in blood pressure and can happen for various reasons. Now, it's a little bit. So we tend to say if there's manipulation of tumors, sometimes we can put somebody into a crisis. So normally the way the crisis is treated is with an octreotide, either usually if you have the ability through an IV, and usually we'll use 250 to 500 mics of octreotide, and then we can continue to ramp this up as well, depending on the severity of it. There was a paper or a presentation last year at NANETS concerning carcinoid crisis, and it had to do with an octreotide infusion, or a lot of centers will do an octreotide infusion prior to and during surgery to try to minimize the rate of a carcinoid crisis. This particular study called that protocol into question, actually, and their results were that didn't necessarily need to have this carcinoid crisis protocol during surgery, and the patients did just fine, including with if they did get into trouble using fluids and epinephrine as well. So it's somewhat, we tend to follow this protocol for a crisis, but again, I think some of the studies are calling this into question a bit.
Wow.
Great.
I have a question here. Patient asks, meds to the thyroid from a lung primary. Is that common?
No, it's not. But I think I would make sure it's an actual metastatic site. Sometimes they'll light up. The thyroids will. We get the PET scans, and the thyroid nodules will light up, and somebody will assume, well, that must be a metastatic site. So ultimately, you need a biopsy to confirm that, and maybe it is. It's not, again, it's not common, but I've seen really weird things happen in the past as well. So patients will sometimes, we'll see on scans, we'll see breast nodules on a scan, and they have a lung primary. Now, breast cancer is obviously very common, much more common than neuroendocrine. So that particular patient is going to need a breast biopsy, and to confirm this isn't your usual breast cancer.
Mm-hmm. Wow.
All right.
Okay.
We have another one here. What would cause a patient's abdomen to become firm in random areas immediately after eating?
Well, that's hard to tell, I guess. I would want to know a little bit more about the history. Is there a surgical history involved? What has actually gone on in the past? It's somewhat of a unusual presentation, but what are the other associated symptoms? Is there nausea or vomiting? Certainly we think about something like that. We think about bowel blockages.
Okay.
So hard to answer.
We got a loaded one. We have, hi, Dr. Ramirez. I'm one of your patients. Glad to see you. I wanted to ask about the ACTH test. What would be the purpose for me? How often should it be done? And does MEN4 influence the answer to these questions?
All right, so a few different parts to this question. So ACTH is a hormone, and an excess can lead to Cushing's syndrome, and there's it's happens in a minority of lung carcinoid patients, but we certainly see it from time to time in patients. Even with very small tumors, can run into this issue. So if you look back, I think I did a program with your group, or maybe one of the other groups, where one of my patients was actually on this video and talked about her ACTH secreting tumor, and this was just a small tumor, and ran into problems for a number of years until somebody said, you've got this little tiny nodule, let's biopsy it, and it came back as a neuroendocrine tumor. So and then you take it out and your symptoms go away. So normally once it's out, one, you get your ACTH test if you suspect something like this, and then you treat it. So you treat it by resection. Okay. Now, if your ACTH level is positive at the beginning, you take it out, your ACTH level drops, then that's something that maybe you want to follow periodically. I still follow with scans most of the time. Sometimes, again, I'll get that ACTH level if it's positive at the beginning. Now again, if the ACTH level is not positive, there's no role to follow it moving forward. So unless there's symptoms. Now MEN4, that's a whole other recently described entity where patients can develop it's called multiple endocrine neoplasia type 4, and patients can develop neuroendocrine tumors. So it behaves similarly to MEN1. But it's a different gene, but we're starting to see a little bit more of this.
Great.
Well, I have one here. This one, I don't know if it's an ethical question or if they're thinking of the effectiveness. Palliative care as a means of pain management.
Yeah, I think it's a great question, and we use the palliative care physicians all the time, actually. So they're great at what they do. So palliative care is treatment of symptoms. So it's not just pain; it's different types of symptoms that patients may get into. We use them for a lot of times for symptom management, and we're normally pretty good at symptom management as well, but sometimes they have extra tools that they can use, and different experiences. And we work in conjunction with the palliative care docs for this, including pain management. So a lot of times, if I get into trouble with a patient, I can't control their pain for whatever reason, and we're doing different things. But then I say, all right, well, let's get our palliative care docs involved and see, maybe they've got some other ideas with this. So yeah, I think palliative care is very important for patient management.
Okay, we've got another text in here. Pretty specific, but we'll try for it. I'm a midgut ileum NET patient diagnosed in 2012. I have had 3 surgeries due to metastases, 2012, 13, and 18. I had 4 PRRT beta treatments in 2019 through 2020. Was stable for about 18 months. Then several small NET abdominal tumors began showing up last November. Over the past 6 months, have lost 5 to 6 pounds, gone from 160 to 155, physically feel pretty healthy and exercise daily, have some diarrhea, but not daily, but no other symptoms. They take creatine since fall, and bladder was removed. Any thoughts on putting the weight back on?
Well, I think some of it has to do with, all right, why are you losing weight? Is this a nourishment issue? If there's certain labs that we can check, something called a pre-albumin. We can check, and that'll give us, is nutritional status. A lot of times patients are malnourished because they're not absorbing, or other reasons. Sometimes they have pain where they don't eat, or not, bowel blockages, and so there's a lot of reasons for someone to be malnourished, and that's sort of the big thing. There's there are medications that we sometimes use to help stimulate the appetite. They're sort of hit or miss. There's a handful of them that we use. And then there's other things for people who can't eat for whatever reason. Sometimes we do nutrition through a feeding tube. Sometimes you do nutrition through the IV. It sounds as if if this is it sounds like this particular patient is taken care of at a net specialty center, with all of this treatment. So I think that's a good question. Normally, even speaking with the dietitians at the centers is sometimes a good place to start too.
So I think we're running a bit short on time. We're going to keep going for a little bit. We don't want to keep Dr. Ramirez all afternoon, but we've got a few more that I think we can cover. I think you briefly, why would a physician prescribe Somatostatin LAR versus lanreotide?
Okay, very, very good question. So the two, both Octreotide LAR and lanreotide are what we call somatostatin analogs. So we use somatostatin analogs in the treatment of neuroendocrine tumors to do a couple different things. One is in patients who have functional tumors and are symptomatic with the Carcinoid Syndrome, diarrhea, flushing, wheezing, these kind of things, they can help control the symptoms. But two, we also know that these medications can help stop the growth of these tumors. So the differences between the two, they're very similar, but the trials were a little bit different, and the FDA approvals are different as well. Okay, so Octreotide LAR is FDA approved in patients with Carcinoid Syndrome. That's the FDA approval. Lanreotide is FDA approved for patients with Carcinoid Syndrome, and it has a second FDA approval to help slow the progression of disease. So that's two different things. Now, does Octreotide slow the progression? Probably so. And we have data that suggests that shows that. So now, are the two interchangeable? Does one work better than the other? So the two have not been compared head to head. Lanreotide is the newer one. They get administered differently. Octreotide LAR goes into the muscle. Lanreotide goes into the subcutaneous tissue. Some people can't get it into the muscle, so the needle doesn't go that far. So sometimes you're doing an injection and it doesn't work, so we change to lanreotide. What I tend to do is, if a patient comes to me and they're on Octreotide LAR and they've been doing well on it for a long time, I don't see a reason to change. If a patient is brand new, I'll tend to start them on lanreotide, just because we have that data suggesting improved progression-free survival, but also there's data in lung with lanreotide now as well. So I'll tend to do that first.
Another text in, would you recommend octreotide for non-functioning tumors?
So non-functioning meaning there are no hormone secretions, those kind of things. I think most of the studies with lanreotide anyway required uptake on your dotatate PET or your Octreoscan. So to do this for somebody who does not have uptake, sometimes we'll do this, but again, we don't have the best evidence for this. So for instance, if a patient comes in and they've got disease, they've got a lung tumor, and I get a dotatate PET and there's no uptake on their PET, indicating they do not have somatostatin receptors readily seen, lanreotide is probably not the first drug I would think about.
Okay. PRRT for lung primaries. I believe that's a clinical trial. Do you have an update or any idea what's going on?
Yeah, so there's trials ongoing with lutetium-177 in lung. We actually have a trial that is about to be open in lung using lutetium-177 versus everolimus. So there's one FDA-approved therapy for lung carcinoid patients. It's everolimus. So what this trial is doing is taking half the group and putting them on lutetium, and half the group putting them on everolimus, and seeing which one works better at the end of the day. Now that is years away from results, but we do PRRT in lung primaries, and guess what? In our experience, it works really well.
Perfect. We have a DIPTEC patient. Want to know if there are treatments other than watch and wait, what they are, and how much concern should they have with their diagnosis?
Yeah, so DIPTEC is what we call a pre-malignant condition. So not necessarily a cancer, but can develop into carcinoid tumors of the lung. So it's an acronym. It stands for diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. And how patients normally present is with a cough or a shortness of breath, and get diagnosed with asthma or COPD or some other more common things. And it's not until we do an X-ray and we see pulmonary nodules and just some characteristic findings on the CT, and then a biopsy is performed showing this increase in neuroendocrine tumor cells. So the treatment is sometimes we watch it. It depends on the symptoms. So if I've got someone who's not that symptomatic, but they have this, we watch it. We'll normally watch it with CT scans and sometimes pulmonary function testing. But when it comes time to treat this, then we generally will move on to a somatostatin analog, and in most cases, this will improve the symptoms of this. But I've got plenty of DIPTEC patients that are on that watch and wait strategy.
We've got, I think, one last one from the texts here. It's a follow-up on that octreotide question for non-functioning tumors. If not octreotide, what are some of the things that you would try first?
So this is, I guess it depends on the primary site. If it's a lung and it's non-functional, I think everolimus is a very good option. Sometimes there's some chemotherapy options as well. We in lung anyway, we use a combination of capecitabine and temozolomide periodically. So clinical trials as well. If it's outside of lung, GI or pancreas. In the pancreas tumors, again, the CAPTEM, sometimes there's another drug called sunitinib that we use in pancreas tumors. We use a lot of local therapy in the GI nets, so embolizations, surgical debulking, these kind of things.
Wonderful. We have one final question, and I think this one is a loaded question. It's an easy one though. They want to know if we will see you in Atlanta in November.
You definitely will see me in Atlanta. I'll be on day number 1 before I have to head out to another meeting for day number 2. So unfortunately, I only get to spend one day with everybody. But yes, we'll definitely be there. I'm looking forward to it. I guess the last one was in Las Vegas. Is that right? Yeah. And before that in New Orleans. And
that
so,
was
yes.
big. It's definitely a different kind of meeting. Anybody who's on and listening, it's worth your time to get to Atlanta. You won't get anywhere with hundreds of other NET patients that you can talk to. You won't go somewhere where we have 22 bona fide experts. Dr. Ramirez, of course, is one of them. So sign up. And if you have any questions or concerns or reasons why you're not sure if you can get there, please email me at bob@netcancerawareness.org, and we'll see if we can get you there.
Excellent.
Yeah.
No, thank you everybody for joining us. Thanks for everybody who participated and asked us some questions. Thank you, Dr. Ramirez, for joining us and giving us your time on a Saturday. If everybody liked what they participated in today, please make sure you tell anybody and everybody to join a chapter meeting, because unless you belong to a chapter, you're not going to get the access that you got today. We have one scheduled for next month. We're excited about that. More details will be out soon. And we hope you enjoyed this. Please check us out on netcancerawareness.org and all of our social medias at netcanceraware.
Yeah, and don't forget, we do have a link if you want to go to Zoom and talk for a little while. You're welcome to hit that link. I'm going to switch over once I leave this meeting, and that's how you can get into what would be like your normal group meeting. So anyway, that's it from me.
Yep. Thanks, everybody.
Thank you.
Bye. Thanks, Dr. Ramirez.